Polycystic ovary syndrome is named after something that in most cases isn't even there. The cysts on the ovaries, they're not actually cysts, and that one naming mistake made decades ago is part of the reason why this condition gets missed, dismissed, or misunderstood for years at a time. So if the name is wrong, what is PCOS actually? Because the real answer has almost nothing to do with the ovaries, and almost everything to do with a hormone you'd usually file under blood sugar. Let's clear up the name first. Those cysts aren't cysts at all. They're follicles, small sacs that each hold an immature egg. In PCOS, a bunch of them stall partway through development and line up around the rim of the ovary. On an ultrasound, that lineup looks like a string of pearls. Someone, decades ago, looked at that and said, cysts! And the name stuck. Medicine is excellent at a lot of things. Naming isn't always one of them. Regardless, here's what matters more. PCOS is the most common hormonal disorder in women of reproductive age, somewhere between 1 in 10 or 1 in 8, depending on how you define it. And a large share of those women don't know they have it. Many spend years bouncing between explanations before anyone connects the dots. Doctors diagnose it using what's called the Rotterdam criteria, essentially 2 out of the 3 of the following: irregular or absent ovulation, signs of elevated androgens, a type of hormone typically higher in males, and that polycystic look on ultrasound. 2 out of the 3, which means you don't even need the ovary findings to have PCOS. So if it's not really about cysts, what's driving it? For a large proportion of women with PCOS, the engine is something we've covered before on this channel: insulin resistance. Up to 95% of women with PCOS have some degree of insulin resistance. Quick refresher. Insulin is the hormone that moves sugar out of your blood and into your cells. When cells stop responding to it well, referred to as insulin resistance, the body compensates by pumping out more insulin to get the same job done. So in the background, your blood sugar level looks normal, but you have chronically high insulin. And here's where it gets interesting. The ovaries are listening to insulin as well. When insulin runs high, it nudges the ovaries to make more androgens, hormones like testosterone, for example. And at the same time, high insulin tells the liver to make less of a protein called SHBG, also known as sex hormone binding globulin, whose job is to mop up excess testosterone and keep it in check. Less mopping, more free testosterone circulating in the bloodstream. That single loop, high insulin, more androgens, less restraint on them, explains the symptoms people actually notice. The acne, the unwanted hair growth on the face or body, the thinning hair on the scalp, the irregular cycles. They aren't separate problems. They're the visible smoke from the same fire. As an internal medicine specialist, this is the part I wish more patients had explained to them clearly, because when you actually measure fasting insulin, the whole picture clicks into place. The ovaries are often the messenger, not the root cause. And just to be clear, insulin resistance is central in a large share of PCOS, but not every single case. There's a leaner phenotype where insulin looks closer to normal and other mechanisms are doing more of the work. So this is the dominant story, but not the only one, to be fair. Now, the part I find fascinating, and where I'll be upfront, that we're moving from solid biology into theory. Quick reset on how evolution works, because most people get it backwards. Evolution has no goal and no plan. Genetic mutations happen at random. The environment keeps the ones that help survival and discards the rest. No agenda, and it doesn't care what any individual wants out of life. It's about what kept populations alive. So, with that in mind, the leading hypothesis. The traits at the core of PCOS, things like insulin resistance and efficient fat storage, look like liabilities now. But for our ancestors facing unpredictable food, they were survival assets. The catch? That same tuning comes bundled with higher androgens, which interfere with ovulation, so fertility does take a hit. But then the environment changed. We went from famine to all you can eat. A system built for shortage now runs against constant surplus, so insulin stays high, and something that may once have aided survival starts behaving like a disorder. Same biology, different world. This is also why PCOS deserves to be taken seriously as more than just a fertility or cosmetic issue, although both of those are real and I'm not trying to downplay that. PCOS can make conceiving more difficult, and that matters enormously to people that it affects. But my point is that the story doesn't end at the ovaries. Because that same insulin resistance driving the hormonal symptoms is also a metabolic stressor on the rest of the body. Women with PCOS carry a higher risk of type 2 diabetes, a higher risk of unfavorable cholesterol and triglyceride patterns, and if you've seen my videos on fatty liver, this will sound familiar. A substantially higher rate of non-alcoholic fatty liver disease, where fat builds up in liver cells largely off the back of the same insulin problem. Put those together, insulin resistance, abdominal fat, blood sugar creeping up, lipids drifting the wrong way, and a familiar cluster starts to form. That cluster has a name, and it's exactly where this channel is heading next: metabolic syndrome. For a lot of women, PCOS is an early window into it. So, what actually helps? The evidence points in a fairly consistent direction. Because insulin resistance sits upstream of so much of this, anything that improves insulin sensitivity tends to improve the whole picture, often including cycles and ovulation. Even modest weight loss, when relevant, can restore ovulation in a meaningful number of women. Beyond that, there are options your doctor might consider. Metformin, which targets insulin directly, combined hormonal contraceptives to regulate cycles and rein in on androgens, medications that block those androgens for symptoms like excess hair growth, and the newer GLP-1 medications I recently covered, which are an emerging and increasingly studied option here. In clinical practice, the thing I hear most from patients with PCOS isn't about any single symptom. It's that for years, no one connected the pieces. The irregular cycles, the skin changes, the difficulty losing weight, all treated as separate problems instead of one. Seeing how they fit together is the first real step towards actually managing it. If this connected some dots for you, the rest of this metabolic story is already on the channel. The insulin resistance breakdown it all rests on, the fatty liver videos, and the metabolic syndrome picture we're building toward. Subscribe today so you don't miss what's next, because I release these breakdowns regularly and they're built to stack on each other. I'm the Science MD, and this is the science behind your health. Thanks for joining, and see you next time.